Hello, welcome back. Today I have decided I'm not going to talk about me. I'm going to talk about someone else, and maybe not the nicest way possible, but always with mental health like at the forefront of what I do and why I'm doing it. So, like, I am super interested. Um, I dorkily enough kind of like legal summaries, not necessarily being part of proceedings. They're boring as heck, but being informed and knowing how lawyers think. And anyway, I'm just trying to say I find the results of legal proceedings fun and not the proceedings themselves. So I tend not to follow things while they're ongoing because it ends up just being conjecture. And there's a lot of conjecture right now going on around Lindsay Clancy, and I don't think it's there's plenty of people who are more informed with facts and dates and timelines and sort of, biological responses and like what's in the realm of possible and not possible. I don't think those trials cut and dry. I do think it's interesting if you like that sort of real life drama saga. But there's one thing that caught my eye because it's the part of the trial that I did actually watch, and that was some of the prosecution of the psychiatrist. And I thought from a mental health perspective, it would at least be enlightening to understand what's going on there if you didn't. When the prosecutor was asking this psychologist or psychiatrist, I think she's a psychiatrist, I honestly can't remember, like what's going on in those moments. So the first thing is that, can your mental health provider testify against you in a court? Yes, under two circumstances. The first is if they're subpoenaed, and their staff or their practice probably will have a legal representative, or they will contact a legal representative, and they will figure out exactly if it is lawful, and if it is lawful, exactly what needs to be disclosed. And you will most likely be informed of that process and that determination. Like, that should not blindside you that your mental health provider has been subpoenaed. The second situation, and you would obviously know about this as well, is if you choose to sue them, and that is what has happened in the Lindsay Clancy trial. She has elected to sue her provider, which I understand. I don't agree with, but I understand. She has chosen to sue her. So her provider is allowed to talk about her mental health, the results of her exams, things like that, because you are allowed to defend yourself in the court. So that's what's going on there. Now, they still have to be truthful. All your other witness standards apply, but that would be, and this should be like fairly common sense. They do have the right to defend themselves in court, and your records would almost certainly be a part of that, unless you're suing them for a completely unrelated reason to your mental health. Like maybe you're in a traffic accident with them or something like that, but I don't know if that's happened. The other thing that some people may question is, well, at least I questioned it because I saw it, was specifically her treatment. The prosecutor was pretty unflattering, unkind, very accusatory to the psychiatrist. I mean, that's their job, but it got to the point where he was so stupid he was mean, and I don't approve of that. And what I mean is, he asked her like why he didn't have access to her medical records, and she's like, because we are a completely separate practice. And he's like, well, what do you mean you don't have records? And she's like, hey, but babe, it's what we all do, right? She obviously was not as flippant as I am on the situation, but that's kind of how I felt. Like, when you are seeking services, your providers do not have access to the medical records of other providers. That's pretty well known, but apparently this one prosecutor did not know that. You have to sign a release and otherwise inform a previous health provider to release records. I mean, I'm doing that right now with dental records, right? Like, my son's got braces. I had to request his x-rays from his previous orthodontist to be transferred to our new orthodontist. That didn't happen automatically or come with us. Really, really pretty shimmers here. So, I don't know. It seemed a little stupid. And what he was trying to get at, and what he eventually did get at, was, well, why didn't you request those records? Could she have signed a release? And the answer to that is yes. But if you present sufficient information, and if you present as if there's no history, and if you are forthright in your treatment and what has been the outcome and your issues and stuff, there may not be much to gain from your medical record, and it may be more of an invasion of privacy than would be justified in the benefit of trying to obtain your records. So there is a cost benefit calculation, especially because there's obviously an administrative burden in securely transporting that information, making sure that it's securely stored. And also, as clinicians, especially in the mental health service, I don't know if this is for, I don't know, we'll call it corporal health, your bodily health. We actually try not to burden our patients with anything unless we specifically believe that that is going to help them as part of their long term. So I don't necessarily know that there is any wrongdoing. And again, I'm not privy to her medical records, so I don't know that. But the justification the psychologist, I keep jumping around with her job title, the psychiatrist gave was, from a, again, I'm a student in the field, but from a legal standpoint was absolutely perfect. She presented herself in such a way that she did not feel that records were accurate or necessary to provide treatment. Could that have been an oversight? Yes. But I don't even know that it was. I don't know that. And then there was the follow-on question that I did see, which was, I need to gather my thoughts here. Oh, when he was critiquing her clinical notes, and at one point she had said, not hyper, pressured speech. And that is part of a mental health status exam or evaluation. It's an informal exam, but it is also it's a formal but unstructured exam is what I'm trying to say. There are certain things you have to cover. The patient's appearance, their behavior, their mannerisms, how they speak, their tone of voice, rate of pitch, all of those are in that exam. So she was literally, that's what that came from. I can tell by the content and style and coverage of those notes that's what that was part of. She was saying, how is the client presenting herself in this moment? And that is a huge distinction that I would like to point out, is that it is only in this moment. You cannot observe the behavior of someone who is not in the room with you, that you're not privy to those actions. You don't know how she is. So she comes to you and she says, hey, I'm normal. These are my symptoms, XYZ. She appears normal. You as a provider, you're going to exercise your clinical judgment, and your clinical judgment is going to tell you that that person may not be as well off as they are presenting. They may be significantly worse. So those kind of exams are very good at catching someone, say, if they are bipolar and they are presenting with, I'm sharpening this lip pencil, by the way, if you're wondering what I'm doing down here. She is bipolar and she is, presenting with active symptoms of mania. You would catch that in a mental statics exam. You may be, interestingly enough, if someone has an identity disorder, maybe you could catch something like that if it happens in the moment. But it's not guaranteed, and it's not a requirement. You are not required to sit with your patient during that exam. You probably are going to allot 45 minutes to an hour. You are not, for an initial one, by the way, you could obviously, you're going to conduct those at each and every, make clinical notes at every client presentation. But like, you're not going to catch someone with, suicidal thoughts. If they tell you they don't have any, you're not going to catch that. You're not going to ask, did you call a suicide hotline, when that client tells you no. If the client does not present with symptoms of suicidality, you may not even run a suicide assessment, which just makes sense. Now, obviously, we are going to err on the side of caution. Like, we're going to do a suicide assessment if we have the slightest belief that you might need that treatment. But it is, again, not as cut and dry, because if you don't present us with a reason to run that assessment, like, why would we do it? Why would we waste time and resources in evaluating you for a condition that we don't believe you have? Mental status, that's what they are, mental status examinations pick up in the moment. They do not identify long-term pressing needs. They would not identify suicidality unless that suicidality is expressed. It's not going to identify dark and distressing thoughts unless those distressing thoughts are somehow animated or made apparent before the clinician. And that is, no clinician should feel bad if they do not pick up on that, because you're not going to. And I am sure her psychiatrist is kicking herself. I'm sure her psychiatrist is going, man, I wish I had known that, or I can't believe I missed that. But it is not clinical incompetence to not be able to see a behavior that did not present before you, right? Like, the behavior wasn't there. It's kind of like, nothing to see here, people, nothing to see. The behavior wasn't there for you to diagnose or observe. It's kind of like with the statistic of like how many people, have depression. I was highly depressed for years. I was suicidal. And I don't think anybody knew. I don't think my coworkers knew. I hope my family didn't know. Like, it's not, my social workers, I had 2 social workers and then 2 psychiatrists and then a pharmacopsychologist. And the I had a psychopharmacologist and a regular psychologist. Those were the most beneficial for me. But like, even they couldn't tell when I was presenting. I had to tell them, hey, these are the thoughts I'm having. So I am erring a little bit on the side of these psychiatrists' professional competence. And not knowing that. And back to the not hyper, not blurred speech. Like, I could tell she was getting frustrated with the prosecutor. I was getting frustrated with the prosecutor. That means the same thing. Hyper refers to rate of speech. Pressured refers to, it's just a descriptive indicator. Like, how does it feel that the speech is coming out? Does it feel like they can get all the words out? I don't even know the formal definition of it. I was never taught that. We just said, is their speech pressured? And we all understood that. What we were assessing for. So him saying, like, when you said her speech is not hyper, pressured speech, that means it was pressured. And she's like, no, it means it was not pressured. Like, I know what I wrote. And he's like, well, you don't have the word not here. And she's like, well, there's a comma. Which, by the way, is short for and, if any of you have done editorial work. A lot of times the comma is substituted for and. Instead of comma and, it's just comma. That is not correct English, and yes, I hate it, but that is extremely, extremely common when you pay by the character. Or if you're typing clinical notes, and this is part of treatment outcomes, but maybe not your favorite your favorite part of being a service provider. So, anyway, if you have 4 brain cells, you would understand that what that means. That is, her speech was not fast. It was not trying to come out of her mouth too fast. She was able to focus. I've seen people with hyperpressured speech, and you can absolutely tell that there's something weird going on with their body. And as it happened, he was manic during a bipolar episode. And I'm like, oh, that makes sense. That checks with what I'm observing. I got to see that. So, like, I understand exactly what she's saying and what she means. And for him to, like, be like, no, that means her speech, Lindsay's speech, was pressured. It wasn't hyper. It's like, okay, describe to me what you're saying. Describe to me what you mean when you say her speech was hyper and not pressured. What does that look like to you? Like, is the question that you're asking the psychologist, does it make sense? Ugh, I switched your job title again. I'm telling you, I'm bad about that. Does it make sense to you, or are you trying to live in a gotcha moment? Like, she is saying her speech was not hypered nor pressure. That is what that means. And you're like, no, it's not. And you're like, you're arguing to the person who wrote it. Like, I think she knew what she meant. And it's not like there's a missing word. It does say not at the beginning of the sentence. And I think that could be reasonably inferred to mean it was neither nor, especially knowing how similar those words are and how they're adjectives used to describe someone's rate of speech. And she's saying everything else about her in the previous notes was also normal. So it's just frustrating that he's like, but this is what you said, right? And she's like, it is what I said, verbatim what you're reading. No one's arguing that. She's like, but you're deliberately, and I think she was much nicer about it than I would have been. She said, no, you're misinterpreting what I wrote. I would have said you're being willfully ignorant. Like, my sarcasm would have gotten a hold, and I would have been like, oh, if only we had a licensed professional, and in fact, even the one who wrote it, to interpret those notes for you. Only if, and that's why they tell us in clinical case notes, like, they tell us to write as if someone is going to read them and prosecute us. They don't say the prosecute part, but that's why. Write as if someone who does not have any knowledge of mental health is going to be reading those notes, because stuff like this will happen. And even though it is obvious what she meant, and even though she provided an explanation, he is still trying to make it seem like the patient presented in a way that the patient did not present, and he wasn't even there. So, like, I'm still kind of on the psychologist side, because I am not seeing the evidence of mistreatment. It sucks. Like, I will say our mental health care system is failing. To use this system is kind of an exaggeration, because that implies that there is a system, and there's not a system of healthcare in the United States. There's no interlinking organizations or processes that would constitute the definition of a system. We're not working together. We have some of the worst healthcare among the developed nations. So, yeah, I use the term system liberally when it talks about our healthcare, but it is failing. It is understaffed. It is under-resourced. It is underfunded. Like, all those things. And is that failing her? I mean, yeah. It is. It is failing her. Regardless of the children in this situation, mom was failed. So I really wish we wouldn't wait for consequences like this to happen to then acknowledge that maybe we need to do something about mental health. Like, why do we wait until it's a crisis and we're investigating people for murder instead of maybe, I don't know, treating them at the beginning? And continuity of care And, access to medication is absolutely part of that. And it's evident that her continuity of care may have contributed to a worsening of her conditions. I always encourage people to, shop around. But if you do shop around, make sure it's to find a person who's a good fit for you, not just to continually be on the lookout. Find the one and then, I don't want to say marry them, but try to make it work, because they're the only person who has that complete picture of you. I can tell you from having a new provider, this was before the Air Force standardized that you will have a continuous mental health care provider. Having a new provider every single week was pretty much fucking worthless. Sorry, the language did sneak out there because of how bad of a policy that was. And now they're better. Now when you're assigned a provider, that's your mental health provider. But yeah, you'd go in and be whoever was available today. Oh, your appointment was to so-and-so today. And I'm oh, who is that? And then you're supposed to be talking about these really, really vulnerable deep moments. I was that's not happening. So don't do that to yourself if it can be avoided. We call it therapeutic breaches. If your provider breaches your trust somehow, bring it up with them. If they're not completely and totally incompetent, they should work with you to repair that trust. They should be oh, I did not mean it this way. Here, what can I do to make it better? Or, oh, I was not aware of that. I will not do that from now on. Oh, well, here's what I meant. Is this something that you can work with? But the conversation will be had. If they're, again, not completely inept. And we call those, those kind of breaches happen, and you do have to kind of build that rapport. That's in the therapeutic relationship. So it's not actually the worst thing that can happen. But anyway, the point of this is to kind of talk about and assess what's going on from the psychiatry realm, and why I don't think her psychiatrist is going to be held liable. She didn't have the information that she needed to make an accurate assessment of the risk that Lindsay was facing, and that information was not available, and she did her diligence in assessing for it, and it wasn't apparent. And like I said, that kind of condition may or may not be apparent at any given moment. A lot of us put our best faces forward. We say everything's fine until it's not. And that's not, it's definitely not helping out our psychiatry partners. And then I don't think the prosecution really, I don't think they understand. I think they're grasping for straws when they say, oh, well, you missed this or this or this, because that's not evident from the clinical case notes. But don't see your psychiatrist if you want that to remain private. And if you have any questions, let me know. If I don't know the answer, I will be very happy to look it up, because this is something that, again, I really want to know about, and that I find very interesting because of how closely related our fields are. But don't let this get you down. Remember that you are in charge of your own actions. Even if you have a mental health condition such that Lindsay had, there is always hope. There is always hope that never goes away. You may be in treatment for the rest of your life, but you can carry that hope with you. So I hope this reaches you if you're someone who needs to hear it. Just like at one point in my life, I was someone who needed to hear it. Beauty is on the inside, and you guys have a wonderful day.